Hello everyone and welcome to my channel. So we have started the neonatology and we have discussed the following topics. These are okay. This is the neonatology. We have discussed the birth asphyxia, the respiratory distress syndrome, the neonatal sepsis, and the jaundice neonatal. In this video, we will discuss the hemorrhagic disease of the newborn and neonatal seizures. And in the next video, we will discuss the large for gestational age and small for gestational age and prematurity and hypoglycemia. So starting from the first topic of today's video, we are having the hemorrhagic diseases of the newborn. This is the topic for today. Okay, so we are having a scenario that there is a 2-year-old infant brought to hospital with history of some blood in stools and vomitus. Baby was born at full by normal spontaneous vaginal delivery. She is taking her mother's milk and is passing urine and meconium. Her general condition is good and has no anemia, jaundice, bruising, skin rash, or hepatosplenomegaly. Another scenario is that there is a 5 days old newborn come to OPD with complaints of oozing of blood from umbilicus and also blood in urine since morning. According to the mother, the baby is full term normally at home and cried immediately. Mother feed started few hours after birth and now baby is exclusively breastfed. On examination, baby is active, alert but pale, vitals are stable and there is small cephal hematoma on right side of the head. So, what is the definition of the hemorrhagic diseases of the newborn? It is a temporary coagulation defect due to a vitamin K deficiency resulting in spontaneous hemorrhage. The causes of the hemorrhagic diseases are early onset. Early onset is due to maternal drugs, that is phenobarbital, phenytoin, warfarin, rifampicin, isoniazid that interferes with vitamin K. The classic disease is breastfeeding, no vitamin K prophylaxis at birth. Okay, this is a classic disease and occur due to breastfeeding and no vitamin K prophylaxis at birth. The late onset causes are cholestasis, that is malabsorption of vitamin K, biliary atresia, cystic fibrosis, and hepatitis, chronic diarrhea, malabsorption syndrome, and prolonged antibiotic therapy, that is a suppression of the colonic bacteria. These are the causes of the hemorrhagic diseases of the newborn if the onset is late. Now, the investigation options that are done for the hemorrhagic disease are prothrombin time, that is activated partial thromboplastin time (APTT), and clotting time and are prolonged. The levels of factor 2, that is prothrombin 8, 9, and 10, are significantly recorded. The bleeding time, that is fibrinogen, factor 5, and platelets are normal. The diagnosis is confirmed by demonstration of the non-carbohydrate proteins in vitamin K absence in the plasma. Now, the prevention is done that vitamin K should be given to all the newborns prophylactically at birth, and the dose is 1 milligram intramuscularly. Intramuscular route is method of choice, but if vitamin K given orally, it is given 1 to 2 milligram at birth, then at the time of discharge, and then after 3 to 4 weeks. The treatment options for hemorrhagic diseases are that the treatment with vitamin K should be given immediately and not without awaiting the test results. Injection vitamin K is given 1 to 5 mg intravenously with the improvement of coagulation defects and cessation of the bleeding within few hours. Intramuscular injections should be avoided in infants who are bleeding. Serious bleeding, particularly in premature infants or those with liver disease, may require transfusions of the fresh frozen plasma or whole blood, that is 20 ml per kg. The differential diagnosis of the hemorrhagic disease of the newborn are swallowed blood syndrome, withdrawal bleeding, disseminated intravascular coagulation, hemophilia, isoimmune neonatal thrombocytopenia, and peptic ulcer. These are the most common differential diagnosis of the hemorrhagic disease of the newborn. So we have discussed one of the common topic, that is hemorrhagic disease of the newborn, and we have some symptoms that there is bleeding from the patient in the while passing the stools, and there is meconium present, and also we are having the history of blood from the umbilicus. So the definition is temporary coagulation defect due to vitamin K deficiency. We have discussed the causes of the early onset hemorrhagic disease and the late onset. Then we have discussed the investigation options, that is PTA, PTT, and clotting factors, levels of the factor prothrombin, bleeding time, and diagnosis confirmed by demonstrated of non-carboxylated proteins. Then we have discussed the prevention for the hemorrhagic disease, and then the treatment options, and then the differential diagnosis for the hemorrhagic diseases of the newborn. Now coming towards the next topic, that is neonatal seizures. Neonatal seizures. Okay, so we are having a scenario that there is a full-term infant born by NVD in the hospital, and he develops fits in 24 hours after birth, which are generalized and recurrent. His growth parameters are normal for his age, and there is no dysmorphism or congenital anomaly. So, mention the causes of neonatal seizures. The another scenario is that there are 8-month-old infant presented with recurrent episodes of flexions of palms involving the neck, trunk, and limbs for the last 1 month. The birth events were normal. There is no family history of convulsion disorder. Parents are unrelated. Elder two siblings are normal. Okay, so this is the neonatal seizures that we are having. The history of normal NVD. The fits is present in first 24 hours after birth, which are generalized and recurrent, and the growth parameters are normal. In this, we are having the episodes of flexions of palms involving the neck, trunk, and limbs for the last 1 month, and birth events were normal. So, the diagnosis is the neonatal seizures. We are having the definition that seizures occurring during the first 28 days of life is called neonatal seizures. The seizures are mentioned as neonatal when it occurs in the first 28 days of life. Now, the causes of neonatal seizures are perinatal asphyxia, hypoxic ischemic encephalopathy, intracranial hemorrhage, metabolic abnormalities, that is hypoglycemia, hyponatremia, hypernatremia, hypocalcemia, and hypomagnesemia. Different infections, that is meningitis, sepsis, and DOJ, inborn errors of the metabolism, congenital malformations, kernictures, tetanus neonatum, pyridoxine dependency, drug withdrawal, that is narcotics, benzodiazepines, and barbiturates, and the familial neonatal seizures. Now, the investigation options that are done for the neonatal seizures are blood glucose, calcium, and electrolytes, magnesium, phosphate, urea, and creatinine. All the electrolytes are investigated. Then CBC is done, that is blood culture and septic screen. Then CSF examination is done to exclude the meningitis or sepsis. Metabolic profile is checked in case of inborn errors of the metabolism. Cranial ultrasound and CT scan is done to rule out the intracranial hemorrhage, brain malformation, calcification in the case of toxoplasmosis and cytomegalovirus. EEG is done, and the lumbar puncture is done to rule out the meningitis. The management options for neonatal seizures are general measures, which are ensure the clear airway and support ventilation by giving oxygen inhalation, set up an intravenous line for infusion, maintain baby's temperature, and put nasogastric tube and aspirate stomach contents to prevent vomiting and choking. Keep nil per oral until seizures are controlled. Monitor heart rate, respiratory rate, and skin perfusion, and send sample to the laboratory for blood chemistries. Okay, so the specific measures for neonatal seizures are that give 10% dextrose water 2 to 4 ml per kg intravenously to control the hypoglycemia. If seizures are controlled, then give continuous infusion. If seizures not controlled, then give 10% calcium gluconate. Okay, first of all, dextrose water is given. If the seizure is not controlled, then give 10% calcium gluconate. If still is not controlled, then give anticonvulsant therapy, which are phenobarbital, phenotines, diazepam. And for intractable seizures, give pyridoxine. The new drugs which are used are topiramate and felbamate, lamotrigine. And the prognosis of seizures is that it varies with the cause. Hypoglycemic seizures have excellent prognosis, congenital malformation have poor prognosis, and symptomatic hypoglycemia have 50% risk of the meningitis. So we have discussed the case of the seizures, that there is a history of the patient who is having seizure after 24 hours of birth, and we have discussed the definition of the seizures. Then we have discussed the different causes. This is the definition. This is the different causes, that is perinatal asphyxia, intracranial hemorrhage, metabolic abnormalities, infections, inborn errors, congenital malformations, chronic chest, tetanus neonatum, paradoxin dependency, drug withdrawal, and familial neonatal seizures. The investigation options are blood glucose, CBC, CSF examination, metabolic profile, cranial ultrasound or CT scan, EEG, and lumbar puncture. And the management options are both the general and the specific measures. And then we have discussed the prognosis. In the next video, we will discuss the large for gestational age, the small for gestational age, and the appropriate for gestational age. Thanks for watching.